Good evening, everybody, and thank you for tuning in to Icon's Facebook Live. Tonight we're going to tackle the very broad but very interesting subject of blood cancers. My name's Ian Irving. I'm a practicing haematologist at Icon Wesley and also Icon Mackay. And in addition, I have the great honour of being Icon's Chief Medical Officer, a role I've done for the last 10 years. Last month was Blood Cancer Awareness Month, and so tonight we're going to talk about all things related to blood cancer. Blood cancers or haematology is a very dear topic, not only to me, but to Icon Cancer Centres. Icon, back in its previous incarnations over 35 years ago, was started by three very forward-thinking, senior and entrepreneurial haematologists at the Wesley Hospital. And to this day, Icon continues to treat a large number of patients with blood cancers, including at Icon South Brisbane and Icon the Wesley, together running the largest autologous stem cell transplant program in the country, public or private. And tonight, to talk about blood cancers, we have three very experienced haematologists, and I will introduce them now one by one. Firstly, Dr. James Morton. James is a dear friend of mine and has been a mentor to my career for many years. James is a haematologist at Icon South Brisbane, as well as Royal Brisbane and Women's Hospital. He's been awarded an AM for his services to haematology and to autism, and some years ago was named as a Queensland Great. So James, thank you very much for joining us. It's great to have you along tonight.
Thanks, Ian.
Thanks. Secondly, we have Dr. Georgina Hodges, who's a senior staff specialist haematologist at Princess Alexandra Hospital in Brisbane, and also a haematologist at Icon South Brisbane. Georgina treats a wide range of haematological malignancies and is an expert in lymphoma, particularly Hodgkin lymphoma and acute lymphoblastic leukemia, very deeply involved in the ALLG, where she performs research into Hodgkin lymphoma and acute lymphoblastic leukemia. So welcome, Georgina.
Thanks, Ian. Thanks for having me.
Thanks. And thirdly, we have from Adelaide, Dr. Deepak Sehgal. Now, Deepak is an experienced haematologist and transplant physician who specialises in stem cell transplantation, as well as the treatment of myeloid malignancies, including myelodysplasia and acute myeloid leukemia. Deepak practices out of Icon Cancer Centres in Adelaide at Tennyson and Windsor Gardens, also has a very large practice at the Royal Adelaide Hospital. So all the way from Adelaide, thank you very much, Deepak, for joining us tonight.
Thank you, Ian. It's great to be here.
Welcome. So welcome certainly to everyone at home tuning in. We're going to go around each of our speakers and talk about a very myriad and varied aspect of blood cancers. Tonight's recording will also be put on the Icon Cancer Centre Facebook page. It will stay there for the next month, as well as being put up on the Icon Cancer Centre YouTube channel. So please share the links to the YouTube channel with your family members, interested parties and friends. During the course of tonight, we of course also welcome questions. And for the last 20 minutes of the 45 to 60 minute symposium that we're going to run tonight, very much welcome your questions. Put them through the chat function, and for that last 20 minutes, we'll try and answer as many questions as we can. We can't get to all questions, and please be careful, as always, about sharing sensitive medical information. So I think it's time now to hear from our experts. James, I'll go to you first, and I'll just ask you to explain to our audience the term blood cancers, of course, is very broad. It's not just one disease, such as breast cancer maybe, or of course there's subtypes in that condition too. But the term blood cancers is very broad. Can you give our audience an idea of what is meant by the term blood cancer?
So, Ian, blood cancers effectively are tumours that are derived either from the bone marrow or the lymphoid system. So from the lymphoid system, we get lymphomas. Mentioned Georgina's interest in Hodgkin's lymphoma, and then there's non-Hodgkin's lymphoma. In the bone marrow itself, multiple myeloma. Of course, the leukemias, both acute and chronic, that Deepak and Georgina have very well developed interest in. And then, as mentioned, myelodysplasia, which is a sort of dysfunction of the bone marrow as people age and has an increased risk of changing into leukemia.
Right. No, thank you for that, because it is a very confusing term. You mentioned myelodysplasia there. I guess back many decades ago, the name for myelodysplasia was pre-leukemia, and that emphasizes, as you just said, its propensity to progress over to acute myeloid leukemia. Tell me, with the blood cancers, and it's a wide range as you've outlined, what sort of symptoms do people present with? What sort of symptoms should people be worried about that they might be harbouring a blood cancer, James?
I think the obvious one is people with lymphomas who present with a lump. So usually a swollen lymph node will draw attention to those sort of conditions. In more aggressive forms, fevers, night sweats and weight loss are a symptom that we concern about. For myeloma, often the typical presentation is with an abnormal blood test, but the really bone pain is the symptom that we most worry about. The other blood disorders tend to present because of their effect on bone marrow function. So a low hemoglobin that causes anemia, which causes tiredness and fatigue, a low platelet count that causes bruising or bleeding to become very pronounced, or a low white cell count that raises the risk of infection, or people just feel unwell, see their doctor, have a blood test, and the abnormal blood test draws attention to the condition.
Yes, that's quite true, isn't it? We all see so many patients, as you've just said, who have a blood test for maybe just screening reasons, their annual blood test, or it's an insurance medical, and it may pick up an abnormality that then, after further testing, a blood cancer is diagnosed. Just before we go on to Georgina, just something you mentioned there about lymphoma and a lump, James. So, we all, through winter, I think everyone's had at least one cold or flu this year, and following on from COVID, there's been a myriad of viruses circulating, influenza A and B and RSV. So often, you have a cold or glandular fever, and you get swollen lymph glands in your neck, and it happens, and sometimes they can hang around for a while. How do you differentiate those sort of swollen lymph glands from a virus from lymphoma? When should people be worried about lymphoma?
So, Ian, I tell patients about the analogy of playing marbles. And I talk about the little marble we shoot with and the big bunga marble that we're trying to hit in the middle. So all of us have lymph nodes, as you've said, that can swell up with an infection, and you can get lymph nodes up to 2 centimetres in size. So we don't really worry so much about lymph nodes the size of that little marble. But once you get to bigger lymph nodes, like a quail eggs in size or bigger, that's where we start to have concerns, particularly if it's sustained over a period of time. I think the mention of glandular fever is very important. I think all of us as haematologists have been tricked when someone's come with quite a sizable node and it's turned out to be glandular fever. So we'll always, consider that in the presentation. But the size, the texture of the lymph node, and really how long it's been there. So a lymph node that's only been a brief duration is not particularly large. Often we'll adopt a watchful waiting approach and just see what it does.
Yes. Time will often declare what is happening and what is worried. No, thank you, James. Georgina, we'll go over to you. As we'd said in the introduction, lymphoma is a special interest of yours. Now, James had mentioned there are two types of lymphoma, or two main types: Hodgkin lymphoma and non-Hodgkin's lymphoma. Could you tell us briefly the differences between those two types of lymphoma for the audience, please?
Yeah, sure. So I suppose lymphoma can be classified in a few different ways, and there's a few different definitions and features that we use to help differentiate the different types. But largely it comes down to what the original cell is or was that was causing the mischief. So non-Hodgkin's lymphoma is actually also a group of lymphomas. So there's not just one of those, there's many. And it can be divided into B lymphomas and T lymphomas, and again that refers to the immune cell that has started the process. But with non-Hodgkin's lymphoma, the main thing that you're trying to work out in the first instance is whether this is an aggressive or an acute lymphoma, or whether it's a more indolent lymphoma. And that does make a difference for patients, because it does help decide what treatment patients will get, and it also helps decide how immediate or urgently it needs to be dealt with. Hodgkin's lymphoma, on the other hand, is actually the more rare subtype, even though it has the more, I guess, positive name. Hodgkin's lymphoma is defined histologically. So that means that when we find a lump, like James was talking about, and if we determine that we think it's suspicious and needs further investigation, we'll take a sample of that lymph node or the lymph node entirely and have that sent to the laboratory. And there's a whole process that goes on in the laboratory about making that diagnosis, but the pathologists are looking at the different cells and trying to determine which cells are the cells of origin. So in Hodgkin's lymphoma, you can see these Reed-Sternberg cells, they're called, and they look like little owl's eyes. It can be quite striking and definitive, and that's what sort of qualifies Hodgkin's lymphoma. But the two groups are treated differently, and it's important that the diagnosis is correct based on that histology, and then also the staging would be the next thing to try and determine where the lymphoma is and therefore what treatments you might use best.
Sure. So although there might be some pointers, as you say, on a clinical review, taking a history and examining the patient, you're saying, Georgina, that really to differentiate what type of lymphoma, whether it's Hodgkin lymphoma or non-Hodgkin's lymphoma, the biopsy, actually obtaining tissue to look under the microscope, or so the pathologist can look under the microscope, is what's needed to differentiate between Hodgkin lymphoma and non-Hodgkin lymphoma. And I guess, as you've alluded to, it can be quite difficult, the diagnosis of lymphoma, and so a really good biopsy is important. Just as you say, Hodgkin lymphoma is the much rarer type of lymphoma. Really is only 10 to 15% of lymphomas, compared to the other 85-90% being non-Hodgkin lymphoma. But you know, Hodgkin lymphoma used to be universally fatal, and now the outlook is so much better, and with modern treatments, Hodgkin lymphoma is often cured, which is fantastic because it often affects younger people. Do you want to outline, just talking about Hodgkin lymphoma, how we treat Hodgkin lymphoma and how the outlook's improved over the last 20, 30 years?
Yeah, absolutely. So Hodgkin's lymphoma, sort of well before my time of being a hematologist, was largely treated with radiation therapy alone, and with that treatment had some reasonable outcomes, but overall, as you say, was problematic. And then over the next couple of decades, chemotherapy was incorporated, and it's multi-agent chemotherapy. So a number of drugs have been added in over time to create combinations. And in that vein, we now have a combination of multi-agent chemotherapy as well as radiation therapy that is treating most of the Hodgkin's lymphoma patients. But in more recent times, so really just in probably the last decade, we've also had additions of novel therapies, and I think the novel therapies are very exciting, and certainly for Australian patients, they're found their way now to the PBS and to treatment rooms. So the main novel therapies presently are brentuximab, which is a way of delivering chemotherapy directly to a targeted cell. And that helps patients in terms of reducing toxicities as well as being very effective because the drug is sort of targeting those areas. And also the what we call PD-1 inhibitors. So these types of drugs work in a completely different way to chemotherapy. So instead of just sort of causing cell death in a broad sense, they're actually targeting the immune system and harnessing that so that your immune system is actually contributing to the management of Hodgkin's, of the cancer. So we've seen remission rates and cure rates increase dramatically, and for most of our young patients, they can get through treatment, be cured, and also manage without significant toxicities, which was an issue in the past. So it's become a very rewarding consult to see a patient where you can really effectively treat.
Yes, no, thank you for that. Yes, well said. I mean, it is, it's fantastic that most people who are diagnosed with Hodgkin lymphoma can certainly be cured. Deepak, I think it's a good time to bring you in now. We'll come back to you a bit later on, Georgina, to again talk about a really good news story in hematology, and that's acute lymphoblastic leukemia. I mean, especially in childhood acute lymphoblastic leukemia, our cure rates are so good now, and it's pleasing to be able to report, and it's maybe a bit of a teaser for the audience for later in our show, that you can tell us how newer treatments and newer protocols are using some of the techniques that we've used to treat children with ALL in the past, applying them to adults and getting good results. But we'll come back to that a bit later. Deepak, we'll go over to you now and go from lymphoma over to myeloid disorders. I think we said at the start you have special expertise in myelodysplasia, also called myelodysplastic syndrome, or MDS, as well as acute myeloid leukemia, often abbreviated to AML. Now, just as an introduction, because certainly some of the terminology in hematology is quite confusing, can you just explain to the audience listening and watching what is meant by myeloid disorders, and maybe just give brief definitions of what we mean by myelodysplastic syndrome and acute myeloid leukemia?
Definitely. Thank you, Ian. And I'd like to welcome all our audience who have joined us. As we all know, we can divide the blood cells into basically two groups, lymphoid and what we previously used to call non-lymphoid and now called myeloid. Right? So the cancer of the myeloid part of the blood system is called myeloid leukemia, which can be acute or chronic. Previously, myelodysplastic syndrome, which was previously called pre-leukemia, when I was a medical student, it used to be what we called as a wastebasket diagnosis. Right? Someone comes with low blood counts, you do a bone marrow biopsy, you cannot find leukemia, but there is some abnormality that people used to call pre-leukemia. And that actually points out to our little understanding that we had. Right? As with any other cancer, whether blood cancer or non-blood cancers, our understanding has improved vastly, especially in the last 1 or 2 decades. Right? Now we know a lot about these cancers. Hence, now we can very confidently differentiate between different stages of acute myeloid leukemia, starting from MDS and then going all the way up to high-grade leukemias. Yeah.
Yes, quite true. And just sticking then with myelodysplastic syndrome, how is it treated? I mean, of course, there are many subtypes and different types, and different patients will, of course, require differing treatments or not be able to have treatments because of other comorbidities and age. Yes, that's very true. And allowing for that, just in broad terms, how do we treat myelodysplastic syndrome now to try and prevent the pre-leukemia going into an actual leukemia or acute myeloid leukemia?
I think we are living in a very good era when we have got a number of therapies to offer to our patients with myelodysplasia. Right. 20 years ago, the only treatment available was a low-dose chemotherapy, but now we have more advanced therapies which target specifically those myelodysplastic cells. Right. And more recently, the chemotherapy has now turned into an tablet form. Right. Now, the more we know about myelodysplastic syndrome, right, the better we can target that disease. So now we have more and more combination treatments, and I'm very glad to say that many of these treatments are in tablet and capsule form. Right. So gone are the days when people will have lots of vomiting, hair loss, nausea, ulcers in their mouth. These treatments are fantastic. Right. People can have at their home, right? They control the disease very nicely, and more importantly, they maintain the quality of life, right? Which is a very important concern for many of our patients.
Sure. Just changing tack then, Deepak, over to acute myeloid leukemia. What's the sort of typical presentation and type of symptoms that people present with for acute myeloid leukemia, and just broadly speaking, how do we treat acute myeloid leukemia?
Well, as the name suggests, it's acute, right? So most of the patients in most of the situations will present with only a few weeks of very non-specific symptoms. Generally, they feel tired, they feel fatigued. Some people may have night sweats. They might notice some blood blisters in their mouth or some blood spots on their skin. Many of them are incidentally diagnosed when they go to their GP for some other blood test, and GP finds out that their blood tests are not right. So the symptoms are not very specific as such. Again, similar to but AML is generally very aggressive and usually considered an emergency. So if your GP is suspecting AML, there must be a prompt assessment by the hematologist, right? And the treatment should be instituted as quickly as possible. Right. Now,
Yes.
Coming to the treatment, again, great strides have been made in the last, more so in the last 10 years, as you know. When I was a medical student, treatment of AML was very disheartening. Right? We had no new treatment since 1970. Right? And we enter now in the second decade of 21st century, and all of a sudden we have got 10 new different kind of treatments, which are very targeted, very effective, very tolerable, and they present state-of-the-art treatment. And that's not all, right? This field is very rapidly advancing. So I'm very hopeful for the next 5 years.
Yes, no, very well said. Now, hematology, as people listening, I'm sure have gathered from tonight's discussion, but also from, of course, all their reading and potentially personal experience regarding themselves or a loved one. The type of language we use in hematology is very confusing. There is a lot of technical names. I mean, it's half of becoming a doctor is learning the language, and hematology has its own particular language. Now, coming back to you, James, the term myeloma, so the disorder multiple myeloma, when we compare that to myelodysplasia, acute myeloid leukemia, they sound very similar to the layperson, but of course multiple myeloma is actually not a myeloid disorder at all. It's quite a different disorder. Do you want to tell us what multiple myeloma is and how it is different to the other blood cancers, and what is its place in the hierarchy?
So multiple myeloma is a proliferation of cells called plasma cells. And the job of normal plasma cells in the body is to make antibodies. So if we get a cold or flu or have a vaccination, these cells make antibodies. And myeloma is a proliferation of a clone of these cells. It'll often be in parallel with it the production of very specific antibodies called, monoclonal antibodies that we detect as a clonal population by doing a blood test. You'll hear them talk about bands or free light chains. And these are excreted by the myeloma cell and can be used to measure the disease and how it's progressing. These cells generally grow in the bone marrow, sometimes as an even process, sometimes as little lumps, and they can eat away at the bone. So that's why bone pain can be a frequent presentation of these cells. So tumoral plasma cells often secrete a protein that leads to their detection, is used to measure their response to treatment, and initially at least is in the bone marrow, although in later stages it can end up in other parts of the body.
Right. Thank you, James. And as you said, pain is often one of the presenting symptoms, which can make it challenging to diagnose because, of course, back pain is very common to us all. We all suffer at one time or another during our life back pain, and it's certainly multiple myeloma is only a small percentage of the people who have back pain. Multiple myeloma, it's almost the theme for tonight. There's have been great strides in the treatment of multiple myeloma, I think, in our careers as haematologists. Do you want to outline for people, James, sort of how the treatment of multiple myeloma has changed over the last 25 years?
This is a perfect question for an old haematologist, Ian. I can remember in the 1980s and 1990s where really the only treatment we had was melphalan tablets and an autologous stem cell transplant. And in fact, people at that time with advanced multiple myeloma would actually die because of their skeleton, which would fail, and they'd break their bones, they'd lose height, they'd get infections. Really, the first major event that changed that was the use of biphosphonates, which are medications that strengthen the bone, so that greatly reduced fracture risk. And so patients didn't get the advanced skeletal disease that we were experiencing prior. And then around about 2000, the discovery was made of the role of thalidomide. And it's a fascinating story of patient power in that a lady whose husband was dying in Arkansas of advanced myeloma read a very old paper that had a small number of patients in it that received thalidomide for various diseases, and a couple of myeloma patients responded. And she asked the professor there if they could try it, and it worked. And that changed the whole caveat of myeloma, which is probably the disease over my career that has changed the most. And so we have a number of cell pathways that we can target specifically around the proteasome with targeted drugs. And also now molecules, a bit like the story with rituximab, that target the surface of the myeloma cell to direct the immune system to attack it. And coming soon is the use of CAR T-cell therapy, where we actually educate a patient's own immune system to go and target the myeloma cell. And in parallel with this, I talk to my patients with myeloma that come to see me is that we have this stack of cards of treatment that we can use over time, but during their journey, more cards will be added. And this leads to very prolonged survival now for patients with myeloma. And it's truly become a chronic disease that as the myeloma cells change and become resistant, we move on to the next line of therapy over many, many years.
Yeah. Yes, quite true. There's such a myriad of therapies, and as you say, CAR T-cell therapy holds out such great promise for multiple myeloma, and perhaps next year we do a whole session on CAR T-cell therapy. It really is so interesting. But no, thank you for that, James. Now it's roughly halfway through, or a bit over the halfway mark of our program. We have questions coming in through the chat function, and please, everyone watching, we'd love to hear your questions. The questions that we can't answer tonight, we'll certainly endeavour to put up an answer on the transcript from tonight's performance when we put the program up on the Icon YouTube channel. Now, we'll get to the questions in a minute, and we've got some really interesting questions coming in. But I'll just go back to Georgina. We'd promised earlier on that we'd talk about acute lymphoblastic leukemia. James has given us the perfect segue into acute lymphoblastic leukemia, because the treatment of children with acute lymphoblastic leukemia, or ALL, is really a poster child for successful cancer treatment that has been improving steadily since the 1950s, and now the vast majority of children diagnosed with ALL thankfully are cured. Some of these new techniques that have been used in children and some new drugs are applied to adults. Do you want to summarize that story for us, please, Georgina, of how these improvements have come to treat ALL in adults, please?
Yeah, so it is a testament, I guess, to clinical trials and to the way that the global community has participated in that, doctors and patients alike. So a lot of the children's groups who treat leukemia ensure that all of the children who come to them are put onto a clinical trial. And so that way these trials recruit really quickly, and they can get answers quickly, and they've made incremental gains over a number of decades. And some of those trials have shown small points and others more significant points. But the current significant gain that's been made in acute lymphoblastic leukemia has been the incorporation of bispecific T-cell engagers. So blinatumomab is the name of the drug, and it's really another very clever addition to the things we can use to fight cancer. So blinatumomab is called bispecific because it attaches to two different things. It attaches to the cancer cell at one end, and it also attaches to the patient's immune system, or one of the immune system cells, with the other. And it brings those two things together, the cancer cell and the immune system. And in that way, the immune system manages to kill the cancer cell. So it's a very effective therapy. The other good thing is that, again, it's different to chemotherapy in the way that we normally use it, and so the toxicities and such are generally less and more tolerable, and it's improved survival. So there's been two really significant studies, one in the children, as you mentioned, but also in the AYA group and the adults, where they've shown that if you incorporate this drug into the usual treatment of ALL, you can really improve the survival rate significantly. So depending on the age group we're talking about, there's probably 10 or 15% more patients who are cured because of this. The other thing to mention, I think, with that is Australia's contribution to that landscape. So we're a relatively small country as far as clinical trials go, and ALL is the less common of the leukemias. But Australia has managed to demonstrate the use of these drugs in what we call the AYA population, which is the young adults and adolescent group. And that was a group that probably wasn't going to easily be considered in either of the other major study groups. So Australia's made that contribution, which I think is wonderful for patients. But it's exciting to do haematology for these reasons, because things are always changing, and we can always have a little bit of hope that there's a new therapy and a new treatment around the corner.
Yes, no, I mean, you're right. James outlined a few of the amazing treatments for multiple myeloma, these bispecific antibodies that are used in acute lymphoblastic leukemia. Truly amazing technology. These bispecific antibodies or drugs are now being used in other cancers as well, including multiple myeloma, interestingly enough. And of course, there are tri-specific antibodies around the corner. So no, thank you for that. Deepak, acute myeloid leukemia, Georgina has told us, is actually much more common than acute lymphoblastic leukemia. It affects all ages, although, of course, particularly has a high incidence in elderly people. Acute myeloid leukemia, you've already mentioned, is often an emergency. It's often treated in hospital, chemotherapy. Now, some people with acute myeloid leukemia go on to a stem cell transplant, or bone marrow transplant. Can you outline for us, in acute myeloid leukemia, who's eligible for an allogeneic stem cell transplant, and why do we do them in acute myeloid leukemia? How do they actually improve people's outcome?
Great question. We can probably divide the acute myeloid leukemia into two groups. One group where the chances of achieving a cure or a substantial remission is high just with chemotherapy only. And then the other group is where the remission or the control of leukemia is likely to last for a short period of time. And if we do not consolidate the gain that we have made with the transplant, the disease is highly likely to relapse. So there are certain leukemias which are aggressive, right? In those cases, we offer transplant. Now, until 10 years ago, in large majority of Australian centers, transplant was not being offered to anyone above the age of 65. But that paradigm has completely changed, right? At my center, we are routinely offering transplants to people up to the age of 70. And in fact, the first patient that we did above the age of 70 was mine, and he was 72, and very happy to say he's still alive 4 years later. So that talks about, and I'm sure Dr. Morton will allude to it, how safe and effective the transplants have become over the last few years. So patients who leukemia needs a transplant due to its aggressiveness, and those who are fit, they go ahead and have the transplant. Even after the transplant, there's a risk of relapse, and that's where comes the question of maintenance. So there are newer and newer strategies to give a small amount of drugs for a finite period of time to even decrease the risk of relapse even after the transplant. So the whole area of acute myeloid leukemia is advancing very nicely.
Right. Yes, it certainly is, and you actually make a very good point there about. Thankfully, we can offer allogeneic transplantation to older people now because of some of the advances in the field. It still is risky, of course, and people still unfortunately can have complications. As you say, we recommend a transplant, put people through an allogeneic transplant to try to have their risk of relapse of the leukemia lowered significantly and in turn lead to better overall survival. But of course, as you say, Deepak, it's not perfect. You still unfortunately can relapse after an allogeneic transplant. We'll go to our questions now. We've got a few coming in, and I'll go rapidly round the three of you asking these questions. First question, James, comes from someone asking about when investigating an enlarged lymph node, can an ultrasound differentiate between a normal lymph node and an abnormal lymph node, and are the ultrasound features 100% accurate for differentiating between cancer and non-cancer in an enlarged lymph node?
Yes, Ian. So the radiologist will report changes in the structure of a normal lymph node suggesting of an infiltrative process. So it provides a guide. There's no way it's clear cut. There's no way it's 100%, but there are certain radiological features that will suggest a pathological lymph node. That said, I go back to the size issue that I said before, which to me remains a very important element of the assessment. And sometimes delaying a lymph node biopsy to be more clear cut actually doesn't disadvantage the patient in terms of outcome. So, diagnosing something earlier versus a little later with many of these conditions, and this is what is unique to blood cancers, the staging is less important to outcome than, say, a breast or a lung cancer. Actually doesn't disadvantage or impact the patient's ultimate outcome.
Yes, no, thank you. Yes, quite right. No test is 100% accurate, and as you say, blood cancers are very different like that, where the staging is different. No, quite right. Deepak, going back to the myeloid disorders, we've had a question come in about chronic myelomonocytic leukemia, or CMML. Now, the question comes from a person who has CMML and is on a clinical trial for CMML, and Georgina has already espoused the benefits of clinical trials, and certainly I think all of us speaking tonight would absolutely echo those sentiments that a lot of these advances in haematology have come about by clinical trials, and would encourage people to seek out clinical trials and to take up the offer of a clinical trial if your treating haematologist feels it's appropriate. So with that introduction, what can we say to a questioner, Deepak, about what is CMML and what sort of disorder is it, and how is it treated?
Well, CMML is one of those hybrid myeloid cancers, which could either behave as MDS or could behave as more aggressive, totally depending on the white cell count, right? So generally, if the white cell count is below 13, right, and if there are appropriate findings in the bone marrow, right, one could consider treatment with the azacitidine or a tablet called Inqovi, for example, right? Certainly, if there is a clinical trial available, that would be my first choice. Right. However, if the white cell count is more than 13, or if the bone marrow shows a bit more aggressive behavior, right, then the treatment has to be tailored. Right. Having said that, there are now combination treatments which we can use for higher grade CMML, again combining azacitidine with another tablet. Right. And in few selected cases, we would consider transplant as well, depending on the genetic makeup of the CMML.
Yes, no, thank you, Deepak. Georgina, I have a question from one of our audience members about rituximab. And they mentioned rituximab being new to Australia, but I think that's not quite the case. I remember when I was training in the mid-1990s, rituximab coming in to treat B-cell lymphomas. Could you just explain, Georgina, what rituximab, which trade name used to be Mabthera, what is rituximab, how does it work, and for what sort of disorders do we use rituximab in the clinic?
Yeah, so we have used rituximab for some time now, but it is more broadly available, I guess, than it used to be. So for more indications. But rituximab is considered a monoclonal antibody. And so it's an infusion that's given through a drip, and it's usually given in combination with other chemotherapies. But essentially it's also targeted. So it attaches itself to a protein or a marker on the B cell called CD20, which is why it's a CD20 monoclonal antibody, and in that way kills the CD20 positive cells. So because lymphoma is quite often CD20 expressing or having that protein on the outside of its cells, then it can target and treat in that way. And I think, blinatumomab is probably the next improvement in ALL that rituximab was in lymphoma. It's sort of this drug that's going to be broadly used that's really improved survival in a whole group of these lymphoid disorders. So rituximab's quite well tolerated generally, and can be used in a whole host of other conditions and various lymphomas.
Yes, and as you mentioned, is often used, you're saying, together with chemotherapy and the rituximab as the immunotherapy, and certainly is used very, very widely. James, not only has the treatment for blood cancers changed, but how we diagnose blood cancers has changed over the decades. In the past, we had what we call morphology, looking down the microscope at blood cells, and we all learnt that skill when we were training. had looking at chromosomes, cytogenetics, I guess in the 1990s and beyond, flow cytometry came in. Now we've got an array of molecular or genetic tests. Next generation sequencing is commonplace. We've had a question come in asking about how do these molecular tests, how does the modern genetic tests like next generation sequencing, how are they applied in modern haematology and what advantages do they give us, James?
So Ian, I will sound old again when I do say that the science is a little bit ahead of the art still, but there are a number of ways that they impact. So firstly, sometimes when we're diagnosing a blood cancer, the diagnosis can be difficult to establish an exact type, and sometimes the gene profile can help us with that. The second thing that gene profile can assist us with is ways of measuring the response of the disease to treatment. So by having a marker, we can very sensitively monitor if there is any disease left, much more sensitive than looking down a microscope. And that can influence us decisions around patients that Deepak was talking about with acute myeloid leukemia, where we have a marker gene that we can monitor and use to determine whether the disease is going to relapse earlier and perhaps move to an allogeneic transplant in that setting. The other way that it's very important now is with targeted treatment. So along with some of these gene abnormalities, there are also very special medications that can target and switch off these genes. And one of the oldest of these is acute promyelocytic leukemia that has a rearrangement between two genes that allow very good response to a vitamin A derivative. And we now treat that disease with arsenic and with this vitamin A derivative, and we measure the molecular test for that gene to ensure the patient's in remission. So it's impacting in a lot of different ways around diagnosis and treatment, but increasingly now is also being used for prognosis, and we're now linking some of these gene types to more adverse prognoses of these groups, creating subsets of patients where we might adopt a different strategy. So, for example, some people with myelofibrosis or other myeloproliferative disease will have an adverse gene panel that may influence our decision around an allogeneic transplant or just continuing with supportive care. So it's really impacting and changing how we look at patients greatly. And at the transplant unit at the Royal, that molecular assessment is part of every decision we make about a patient proceeding or being recommended for a transplant or not.
Yes, no, thank you, James. You're right. It's a brave new world with all these molecular tests, and as you've said, they can be very helpful in stratifying which treatment should be given, stratifying whether a transplant should be done or not. As you've said, they can be used for monitoring, and minimal residual disease is a term we often use now to describe when you can find small amounts of leukemia by these molecular tests, whereas in past years just looking under the microscope, we wouldn't have been able to detect such small bits of leukemia. So no, thank you for that explanation. Following on the technology bent, Deepak, there's a questions come in, and it's not sure. It's always difficult to answer these sort of questions about how to predict the future, but the question revolves around, will AI or machine learning play a role, and if so, what role in haematology treatment decisions for the future?
I'm so happy you didn't ask me that question again.
Yes.
I think it would be blasphemous to ignore the role of AI, which is, all pervasive now. So there's a lot of research going on in different research groups, not only in Australia, but in the States as well as Europe, right? Trying to pick up the combination of genetic errors, right, to which a particular treatment can be tied, right? So that we become more and more specific, more and more personalized in our treatment, right, for our AML patients, right? Right. Now, these type of treatment paradigms are not cannot be designed just on one patient data or 100 patient data. It needs tens of thousands of patient data to be analyzed simultaneously. Right. So we have seen outcomes from this data led by the ML consortium from Memorial Sloan Kettering Hospital, but that was the stepping stone, right? So certainly AI does have the power and the tool and the resources to put a huge amount of data and analyze in a very short period of time. And I think in the next 4 to 5 years, we will reap its benefits.
Right. No, thank you, Deepak. Like James, I wasn't going to be able to answer that question very well myself. So no, well done. George, over to you. This is another good news story, I think, in hematology, but it's a question that has come through the chat function asking about how tyrosine kinase inhibitors work in chronic myeloid leukemia. And, you know, as an introduction for the audience to that topic, of course, chronic myeloid leukemia, or CML, is the abbreviation we use for that condition. It really is a very standard hematological diagnosis. These days we treat with tyrosine kinase inhibitors with great effect. So do you want to explain how they work and summarize this good news story, Georgina?
Yeah, so TKIs have absolutely changed CML, but also other disorders with the same abnormalities. So the reason tyrosine kinase inhibitors work is because there is a translocation, which means a joining of two different chromosomes, in this case, chromosome 9 and chromosome 22. And when those two come together, it also brings together two genes that shouldn't be sitting next to each other. And so a tyrosine kinase inhibitor is a drug that is able to intercept or to block that area. And so you don't get the ongoing proliferation of those abnormal cells. So there's a few tyrosine kinase inhibitors. We started with imatinib, and then it's considered a first generation. There's dasatinib and nilotinib that are considered second generations, and ponatinib, which is the third generation. They all have their pros and cons, and so usually a decision about which one should be used is made, you know, on the basis of what particular side effects and various problems might be encountered with each. But certainly dasatinib and ponatinib have had a huge impact on the treatment of what we call Philadelphia positive ALL. So same abnormality, but a different disease, but still an excellent drug. And I think with all of the molecular discussions and things, when we find these kind of bits of information, if they can come with a therapeutic intervention or change, then that's really where the money is.
Great. No, thank you. Thanks. That's a really good explanation of the genetic changes with that translocation that we see in CML, because certainly they're difficult concepts to explain. Another question has come through, Georgina, and potentially this may be a little trickier to answer, is one of our audience members is asking about diet and foods, and in particular a plant-based diet, and whether such changes in the type of diet someone takes, whether that affects blood production and mutation rates in the bone marrow, or has any effect on bone marrow cancers. What would you say to someone, or what do you say to your patients day in, day out when they ask about the effect of diet and blood cell production?
Yeah, I think our patients commonly ask this question or similar questions because I think when you're diagnosed with a blood cancer, it's a shocking situation to find yourself in. And I think we always want something that we can do. What happened to cause this, but also what can I do to make things better? And in addition to, you know, having a treatment and so forth, how else can I improve my situation? So I think it's a very fair question. So the trouble with blood cancers, though, is, as Deepak was saying, acute myeloid leukemia, acute lymphoblastic leukemia are very aggressive. And so the mutations have already occurred, and they've usually already occurred on the back of other mutations. So sometimes the defining mutation in leukemia that's caused all these cells to proliferate is not actually the first one that happened. There might be 3 or 4 before that or more. And so by the time you're in that situation, there isn't usually a slow, long prodrome of time where you can change things. It's really about trying to address that immediately. So from a, can you alter your disease? No. But I think from you know, how best can you do with treatment, you can improve things. So we do encourage people to eat a wide variety of protein and vegetables and so forth, because what you want to do is try and maintain muscle mass. You want to try and maintain nutrition so that as you're going through different therapies, you're able to tolerate those. So there is a little bit of data for things like vitamin D in lymphoma, and there's an association between low vitamin D and lymphoma, but it's more difficult to prove that supplementation makes a difference in that circumstance. So, you know, I think we encourage people to try and take appropriate health measures. You know, things like smoking and so forth are usually associated with cancer, but I think with aggressive disorders like leukemia, it is usually difficult to make a significant impact.
Right. No, thank you. No, very informative. Thank you, Georgina. We're coming towards the end of our symposium tonight. Final question to you, James, and it's from one of our audience members again. Can blood cancers be hereditary?
So the answer to that is yes. And there are various risks. So when we look at hereditary or risk of hereditary cancers, there are relatively common hereditary pathways with low risk. And then there are rare situations where there is a high risk. Now, in general, when I answered this question, I'll say no, it's not hereditary. But we all have families where there is a familial pattern of lymphoma, CLL, myeloma with overlap that almost certainly have a gene that we're yet to understand that is contributory. So generally not, but there are certainly familial patterns that we do see, mostly rare.
Right. No, thank you, James. Well, I think just before I wrap up tonight's session, again, I thank everyone for tuning in. Before I wrap up, of course, reminding everyone that the transcript and the recording of tonight's session will be on the ICON Facebook site for the next month, and of course it will be put on the ICON Cancer Centre YouTube site as well. So I encourage you to share the links, and of course you can go back and watch the session again to catch up on anything that you may have missed. So before I wrap up for the evening, I'm just going to go around our panel with any last minute pithy message that they would like to depart on this topic of blood cancers, which has been a real joy to present just a couple of weeks after Blood Cancer Awareness Month. So, Georgina, you first. Any last pithy answer or a statement you'd like to make for our audience?
Yeah, I guess thank you for having me. I think that knowledge, whether it's power or not, I don't know, but it's certainly confidence, and being informed definitely helps make good decisions. So talk to your hematologist and ask questions. None of us are ever too busy to try and help you understand better or more to make a good decision.
Yes, very well said. That's right. Patients who come with lists and who ask questions are always at an advantage. Yes, well said. Deepak, it's great of you to join us from Adelaide. Of course, ICON Cancer Centres are around the country, but our centres in Adelaide particularly held dear within the ICON family, being some of our earliest centres. And thanks for joining us, Deepak. Have you got any last-minute message you'd like to deliver?
Oh, it's been a pleasure, Ian. I just want to encourage my audience to enroll into clinical trials, right? It's a very important step in advancing the medical science. And the place where we sit today has been the product of efforts of thousands and thousands and thousands of patients who have participated in many, many trials. Right. So I encourage everyone to seek a clinical trial closer to them.
Yes, well said. Now, the last word goes to you, James, as our senior author. Just like on scientific papers, where at the end of the authorship is the most senior author. Now, I'm not suggesting for a moment that that you're old. You're at the peak of your career, but certainly the most senior hematologist on tonight's talk. So, what's your message, James? You get the last word.
I think my message is that of hope. And, I think back to a lecture I went as a medical student in 1984. I remember it well because the lecturer was a guy called John Hancock, and his last slide was a description of a young lass with leukemia, 4 gene abnormalities, 4 targeted therapies. Now, we're more than 40 years on, but we are now making enormous leaps forward to converting a lot of these blood cancers into chronic diseases. So whilst the terms leukemias, etc., sound extremely frightening, I think there is great hope for the future that many of our patients will see in terms of changes over their journey.
Yes, no, well said. It's a great way to finish. You'd outlined before, James, how the average survivor with multiple myeloma in the last 30 years has gone from 2 to 3 years to over 18 years. In some studies, patients with chronic myeloid leukemia with TKI therapies are actually surviving longer than age-matched controls. All these statistics are amazing, and there's even more hope for the future. So it's a great way to end tonight's session. Thank you to all our speakers. Thank you at home for tuning in. As I say again, please share the link with the family, friends, or those who would be interested to listen. This is our last Facebook Live for 2025. We very much look forward to being back in 2026 after, of course, a break in over the summer, over the Christmas and January period. We should be back doing the Icon Cancer Centre Facebook Live series in February 2026. I look forward to seeing you all then. Have a great rest of the year and best of luck to everyone. Thank you.
Thank you.